He set the stage now for giving the indications for medial compartment resurfacing or unicompartmental surgery. Now, it started off with the Oxford, with the mobile bearings. So I'll speak on that, and then we'll have Suhas talking about fixed bearings. So I'm going to speak on for the medial OA, and then after Suhas, we'll have Dimple speaking on the lateral compartment, and then I'll finish off with the patellofemoral joint. So I'll just talk about 3 prerequisites, the results and advantages. Prerequisites or indications we've just discussed. Again, the anterior-medial wear is important. And this is what we had published many years ago, that it correlates with the ACL integrity and the severity of deformity. Intact ACL is already been mentioned, and here you can see the effect of what happens if the ACL is absent. The survivorship drops. The lateral facet is very important, the patella, so that should be intact. The medial is not so relevant. The lateral compartment should be okay. Sometimes you will find a little pitting over there, a little bit of fibrillation. I'm not sure that that matters. The flexion deformity is very important. We discussed this even in one of the meetings. If it's a 10-degree flexion deformity, it could be more than that even. But if you think that it's largely due to osteophytes, which you're going to remove, and you may be able to correct it either in the notch or posteriorly, then that is not a contraindication. But if it's a contracture and the deformity itself is rigid, both in the flexion deformity and the varus are rigid, that means there's a contracture of the soft tissues, in which case it's not a great idea. You should have at least 80 to 90 degrees of flexion. Sometimes patients have a lot of pain and they don't flex. And the moment you give them anesthesia, somebody who is at 70 and 80 will go up to 120. So again, that is not a contraindication. And how much deformity is acceptable? Well, initially we talked about 10 degrees, and now we're extending the envelope and seeing that that was a number picked out of the hat really. And you can have a lot of patients with even greater deformity where everything else is satisfactory and you can still do a uni. So that 10 we've extended to 15, now we've gone even beyond 15. We did do some studies on the cruciate ligaments in immunohistochemistry, etc. And some structural changes start appearing beyond 10 degrees. So you've got to assess the ACL very carefully. Now, what about the alignment? A big question is in unis, how do you align the uni? In total knees, we had a huge discussion. What is the best alignment? For unis, it's very simple. You put it back where they were before they had osteoarthritis, because you're doing no releases. So really, it's the most kinematic alignment. And that's how actually Stephen Howell got the inspiration to try it out for total knees. Now remember that the bigger the deformity, unlike in a total knee, you're not going to be able to correct it. In a total knee, whatever the deformity that you start off with, you want to end up with some figure which is more or less the same for almost all total knees, irrespective of varus, valgus. You want them in that 180 plus minus whatever. That's not the case with unis. You will leave them in a significant amount of varus for a varus deformity. The greater the deformity, the more residual varus they will have. And very large preoperative deformity that the patient is telling you, I want my leg perfectly straight, and they are starting off at 15 degrees, you have to warn them that you are not going to be at 0 degrees, because then you better do a total knee replacement. You're going to get them less than what they were, but you'll get them to their pre-arthritic condition. We'll come to that in a moment. You have to be very, very careful with minimum deformities. And that's where you can overcorrect these, and then they become very uncomfortable and lateral OA comes in. So be careful when the deformity is less. Exclusion criteria is a prior HTO, inflammatory arthritis, and obesity. These are the 3 things. Obesity itself is a relative contraindication. For the Oxford group, with the mobile bearings, they don't consider it a contraindication. The fixed bearing group does. So we've done these from the age of 39 upwards. up to 91 is our oldest patient. It's more predominant in females in the younger age group and males as you grow older. And we had many years ago described, we started this surgery way back in 97. Our first patient is still going strong, did a fixed bearing uni on one side. About 10 years later, did a mobile bearing on the other side. She's still going strong so many years later. So from 97, we've done several thousand of these unis. Initially, everyone was looking at it very skeptically, and now a lot more people have been convinced that it's probably a good surgery, even in our population. Generally, the mean mean HK gets improved. We aim to put it back where it should be. It's very difficult to decide what the exact alignment should be. And most of these people are extremely comfortable, and almost all of them go home the next day after surgery with very good movement. Most of them don't really need much physio. If they have some quadricep weakness, that's all that they need to do, strengthen their quads. Most of them have excellent flexion. They can sit cross-legged, sit on the floor. And generally speaking, the outcomes compared to total knees are far superior. When you look at matched, this data which has been from matched patients from the UK Joint Registry, you can see the good and excellent results are very good with unis, and even the satisfied patients on the OKS, Euro, Qual, EQ, whatever those scores are, have been shown to be excellent. And there are several papers comparing unis with total knees, suggesting that both pain and functional improvement is far superior to total knees. However, there's a downside, and you have complications, and these are some of the common complications that can occur. Loosening is one of them, OA progression, wear of the polythene over a period of time, the meniscal bearing can dislocate, and you can have fractures typically intra-op or very soon post-op. So this is some examples of these complications. This is somebody done elsewhere, and you can see very poor cementing job. So cementing of the tibial component is very critical. You have to prepare the surface properly and make sure you pressurize the cement. So here you can see within a short time this is loosened out. The femoral component is okay. And because the patient continued to walk and already a significant amount of bone loss had occurred because of the resection. So you got to be careful not to over resect the tibia, because the more you resect, you go into softer and softer bone. And therefore the chances of your component loosening get higher and higher the lower you go. And then you have to put in a stem with an augment. This is one of our patients who came after 10 years, and we thought we'll have to revise it. So when we opened up, we found that the insert had split into two, and both components were perfect. The rest of the knee we opened up to do a revision, a conversion, and we were so surprised to see that the ACL, the lateral compartment, patella, everything were pristine. So all that we did was we changed the insert. That's it. And she's back again. We had another guy coming at 17 years. He's a cricketer. He disappeared for 17 years and came one day with severe pain. Same thing. We looked at the x-ray. It had split into two. We told him, come in. We put a new insert. Gone. Next morning, he was back. And he'll probably not show up for the next 15 years. So they're so happy they don't come back. This is a patient who was done by another colleague in our own hospital, and you can see what's happened. It's fractured. You've got to be careful with the pin placements and not impacting it like a crazy carpenter, you know. The tibial component can fracture, and then again you'll need this augment and stem. Bearing dislocation is the main bane of this surgery, and you have to just make sure that your patients understand what they can and cannot do. Don't, you know, do some crazy yoga and do some twisting movements. You can, or athletics in certain activities where you can dislocate the bearing. So we just counted our last 2000 unis. We had 19 dislocations. bearing dislocations over the last 2000 unis. Most of them you can put in a 1 mm thicker insert. We've had one or two patients where it was recurrent, and therefore we had to revise it to a total knee. And you can get lateral compartment changes if you overcorrect, or if they develop rheumatoid arthritis, as in this patient. Overall, loosening and progression of OA are the main long-term problems. The best part about unis is infection is almost unheard of. Having said that, in our several thousand cases, we've had 2 patients with infection. And generally speaking, the complications are far fewer with unis than with total knees, including mortality at 1 and 3 months is much less than total knees. Total knees is slightly higher, similarly at 8 years. And this is one of our longer term follow-ups, 2005. You can see single peg on the femoral component, and 2015, 10 years, no change in the implant. And in general, the survivorship is excellent at 10 years. The published results from Oxford at 15 years is also excellent, and the 20-year results from an independent series is also over 90%. So with that, let me invite Suhas now to speak on the fixed bearing unis.